What are the first line medications used in heart failure and how do they work? So you can
Right.
give an expanded answer, a brief answer, and we can pick up from where we leave next time.
I will just focus on because I have always given you broad answers, but I'm going to just zero into this. Look at the ejection fraction. If it's reduced ejection fraction, you should be on four meds. You should be on one of these four classes, really. Heart failure, beta blockers. There are three beta blockers that have been shown in clinical trials: Carvedilol, Metoprolol, Succinate, and Bisoprolol. Three. Then you go into the next class, which is the angiotensin receptor antagonism and angiotensin converting enzyme inhibitors, or what we talked about, Sacubitril, Valsartan, which really is the drug of choice, and which is brand name Entresto. That is not attacking the heart directly, but it's actually attacking the body's response to heart failure. A remarkable agent, definitely improves quality of life, longevity of life. Third is SGLT2 inhibitors. They make you urinate. So the sugar, water follows. There's a diuretic effect. Some salt follows as well. There's some hypothesis that there's some regenerative pathways within the heart and kidney, which you know very well, that result in remarkable improvement in symptoms. I think there is about 16 days. 16 days, you start feeling better. So it's a unique agent. You want to lower the heart rate with a beta blocker. You want to dilate the blood vessels. You want to get some volume off and introduce regeneration through the SGLT2 inhibitors. And then mineralocorticoid receptor antagonism. That is multiple trials, spironolactone, eplerenone, and then now there's a non-steroidal agent coming out called finerenone, approved for more than 40% ejection fraction. Now studies are looking at less than 40%, but these agents have been shown to improve myocardial recovery, fibrosis reduction through actions that are unique. There are some side effects that we all know and we should be aware of. But in any case, these four classes for heart failure with a reduced ejection fraction, you have up to 73 to 75% reduction in mortality, relative risk reduction, and hospitalizations. That's it. Once you're on the drugs, you want to go up on the doses, go up to the highest dose you can tolerate, because it's dose dependent as well. So you start, if you can't go up, you have symptoms, you go drop to the lower dose. Doesn't matter if you don't have any symptoms, you still want to try to go to the highest dose. That's where the heart failure guideline directed medical therapy clinics are coming up. So that's reduced ejection fraction. Preserved ejection fraction, you have class 1 SGLT2. You have class 2B, the mineralocorticoid receptor antagonist, spironolactone,